Thank you for the introduction, and thank you for the kind invitation to be invited here on this conference. So this talk is about proton therapy technology and well, its applications in the clinic, and some aspects of radiation protection as well. So if you look at the ballistics, the depth-dose curve of this proton beam, then it's obvious that there is some advantage in there. It's pretty obvious. And if you look at the evolution that we've gone through these last, let's say, 2 to 3 decades in radiation therapy, that is going from very rough, almost regional irradiations to really specific, nice and conformal dose distributions, then you see that this proton beam nicely fits into that evolution, and it's the obvious next step. However, if you look at proton therapy technology, that has gone through some difficult times, and this is what they call a hype cycle. And I believe that, well, right now we are not anymore in that depression here of disillusion in the technology, but we're climbing up this slope, the so-called slope of enlightenment. We see the potential, but we are quite realistic in what to expect. And hopefully, in some time in the near future, we'll end up in this region. And you see that optimism also reflected in the amount of the number of centers worldwide. That was a prediction. Okay, maybe it was too optimistic, but still the number of proton therapy facilities in the world is rising. But to go from this physics, the depth dose, the way protons interact with matter, and this nice Bragg peak, to go to a clinical solution, well, there's something in between, and that is a lot of technology and technological evolution and development. And it's the only way to bring out the full potential of this very nice Bragg peak. And well, I've taken the liberty to go through a few aspects of the technological advances and evolutions that we are going through today. And I will point out some advantages or disadvantages for radiation protection on the way. So let's first start with delivery technology. So this is a layout of a typical proton therapy facility. So you see here the accelerator generating the accelerated protons. In this case, you see a beam line to transport, dispatch the beam over different treatment rooms. And there can be different kinds of treatment rooms, so fixed beams without a gantry, and then a rotating beam by putting the beam line on this type of gantry. And at the very end of the beam line, you have a component that is called the nozzle, and let's focus on that for a while. So the proton delivery technology, well, the nozzle is actually to modify the treatment, the proton beam that is being generated by the accelerator and guided through the beam line, which is typically a very fine beam of a few millimeters in diameter, but that's not enough to treat tumors that are typically much larger than that dimension. So we have to go through from this pencil beam to a broader beam, or at least to be able to irradiate with this proton beam a larger volume, and that is what is happening in the nozzle. A technique with which still most of the patients that ever have been treated with proton therapy is used is passive scattering. And there we create a wide, broader beam to irradiate volumes of the size of typical tumors, or target volumes at least. And what do we do? So we have the very sharp Bragg peak in depth, but we need to create something with the dimension of a tumor, a kind of plateau, and that's what is happening with this range modulator wheel. That's actually a piece of material that is shaped like this, that is rotated at a very high speed, and with this we can create this kind of plateau of high dose that is nicely shaped, or the size is nicely matched with the size of the tumor in depth. So we put some material in the beam. A second thing is to create a wider beam laterally to cover the entire tumor, and for that we need we can use scattering. That's the passive scattering technique here. So we generate a wide beam, and actually we put some specifically shaped objects in the beam to create this wide beam to have the highest possible efficiency, not to lose too much of the accelerated protons, and to create, if possible, a homogeneous intensity. But again, we introduce material into the beam. And then the last step is to do things that is actually customize the distal edge of this wide proton beam to the actual target volume. That's done with a compensator, and also to shape the beam with an aperture to the target volume. And again, we introduce materials of different kinds into the beam. And that comes at a price. So the interactions with these devices, of course, give us the advantage of shaping the beam and customizing the beam to our needs to treat, to irradiate a specific target volume. But there are other effects, secondary radiation, stray irradiation that is being generated, which also hit the patient and not in places where we are treating. So that's a big disadvantage. There are also secondary radiation is also being generated inside the patient, and there's potentially also backscatter from the walls of the vault, and that altogether creates actually a neutron dose bath of the patient being treated with proton therapy. And of course that is of some concern, looking at this paper that discussed that in great length some years ago. So it's definitely something that we have to keep into our mind in proton therapy. There's also activation of these components who are in the beam. If you look at these high Z materials that are being used in apertures, brass, ceraband, then you see you get activation, and it takes several months for them to cool down. Also, the compensators are usually made of low Z materials. They are activated during irradiation, during treatment, and that also takes 30 to 40 minutes to decay back to the background. But in the meanwhile, the therapy personnel is actually changing these because they are specific to each individual beam, and usually you have a set of beams per treatment. So that means that these people are manipulating these activated devices. So there might be some occupational exposure, but very little data could be found on these exposures. There's another type of delivery technology, and that's called pencil beam scanning. And in terms of interaction with matter and creating this stray radiation, this is a much smarter approach in the sense that it uses the Lorentz force to steer the beam magnetically, and basically the beam is not hitting anything during that process. And what is being done, the beam is scanned over the volume of the patient, so we're not modifying the size of the beam, but we scan the beam over the larger size target volume. So here the secondary neutrons are mainly generated inside the patient, but that's unavoidable. But in general, you could say here, or that's the case, the out-of-field dose related to stray radiation is a lot less, which is obviously an advantage. Steering the beam magnetically is one component. You also need to change the energy, because energy is related to the depth of the Bragg peak, and you have to, of course, treat different layers, and each of these layers have a different energy. But that energy selection that involves some interaction with in this case, these wedge devices. So it interacts with matter, so it would create neutrons definitely, but this process can be done upstream, far away from the patient in this process. So that's really an advantage. And the combination of this degrading and changing the energy and steering the beam magnetically in the lateral way gives us all the possibilities, together with the spot weight effect, so the amount of dose you give per spot, gives us all the degrees of freedom to create very nice dose distributions in the patient, as you can see illustrated here. And if you look today at what is the preferred proton therapy delivery process, then obviously it's pencil beam scanning that is gaining a lot, and a lot of the systems that have initially been started up with passive scattering are being upgraded to this technology. And why is that? Well, my dose distribution has disappeared here on the slides, but anyway, you can see it here as well. So PBS generates much less stray radiation, less out-of-field dose, which is an advantage. Now, on the other hand, it is generally accepted that the major component of secondary cancer is related to in-field radiation rather than the out-of-field stray radiation. So most of the gain here is actually to move from photon therapy, where you do not have these regions of no dose because the beam is not stopping in the patient. So most of the gain is to go to proton therapy in general, and actually the delta from PS to passive scattering to PBS is estimated to be fairly small. On the other hand, okay, it is because of the limited or still incomplete knowledge of stray radiation and its effect, you can definitely say that improvement in that respect is still rectified, and we should strive towards reducing that component anyway. So why are we going to PBS? Well, this is an important reason. Well, here you have a typical high dose distribution delivered by the passive scattering. The depth, the range modulation of the spread out Bragg peak is based on the largest cross-section of the target volume, which means here it has a much smaller cross-section, but still this part will be irradiated with this passive scattering beam. In pencil beam scanning, you can avoid that and give these parts a much lower dose, so your dose distribution becomes much more conformal. You have other advantages of PBS, pencil beam scanning, and that is multi-field optimization, IMPT. PBS is always a kind of intensity modulated treatment, but if you combine different beams from different orientations, like IMRT and photons, you have an edge, and you have better tools in your hands, more degrees of freedom to even better spare healthy tissue. However, this technology is very sensitive to uncertainties and to interfield motions. The interplay effect is an important one. So the interplay between the delivery, which is actually a time-resolved process. So you see here that a dose is actually made out of all these small deliveries, and they have to be aligned correctly, because otherwise you will not get the dose distribution that you intend. If you have motion, then it seems the movies are not working. But anyway, so you have the delivery process, there it is. And you have the tumor motion, so the interplay effect between them will make that these different spots are not aligned with each other, and they create a different dose distribution summed up than you intended. So there are techniques to overcome that in PBS, so by, for example, rescanning, so that means actually delivering the dose in smaller parts repeatedly. Why move to PBS? Even if there is a lack in international guidelines, passive scattering and proton therapy that is covered by some guidelines, but PBS specifically is not, or is only touched in a few guidelines. So there are some in the pipeline, but certainly from a clinical point of view, implementing proton therapy in clinic, we are waiting for these guidelines to come out that we can apply them. So that's one evolution. The second thing is compact layout systems. So we've gone through an evolution in the proton therapy facilities. So we started off as a byproduct, so large nuclear research facilities could deliver part of their beam to a clinical environment. Here is an example of PSI, where you see that the medical clinical part is only a very small part of this large facility. Then we move to dedicated standalone facilities, such as these, really standalone facilities, not any hospital in proximity of these centers. And now we move to yet another type of facility, that's the embedded facility, where the proton therapy facility or modality becomes embedded in an existing hospital environment. And actually, a lot of metaphors are used in proton therapy. Trains are very popular, but another one is also used, that is sport fields. And typically you can compare the size of a typical proton therapy facility, of these large-scale proton therapy facilities, with a football pitch. Now today we are moving to different sports, so we have tennis, we have basketball, and indeed today the solutions that are being commercially available are much smaller. So we have these compact systems from both IBA, Varian, and also an interpretation of that, and for example, Mevion. And that's an important step in, I think, one of the important steps in the history of proton therapy. If we've gone from the early days to the first treatments, to first pencil beam scanning, getting it more general commercialization of proton therapy in the 90s. And now we're going to the next important step, and that is these compact systems, these small units that can be delivered. This is an example from Maastricht, where they really implant the proton therapy facility in an existing hospital environment. You see it here. It's completely surrounded by other buildings, and even they broke down an existing conventional X-ray radiotherapy bunker to construct this proton therapy facility. That's another example. That's our project in Leuven, together with all these partners here mentioned on the side. So here as well, we had a leftover here between different other buildings, and we are building our own proton facility in that space, very close, about 15 meters from the existing radiation oncology department. Now, if you look at these large facilities and you look at the different components, basically the components that create secondary radiation, stray radiation, then you see, okay, that's a distribution in these large facilities. If you look at a compact system, for example, here the IBA Proteus 1, you see that, okay, the location and the distances with respect to the patient are quite different than in these large facilities. And that's important in terms of a few aspects. So secondary neutron dose to the patient, if you place, for example, the energy selection system much closer to the patient, then you could expect some additional neutron dose to the patient. If you have a smaller facility, a smaller treatment bunker, there might be more scatter coming off the walls. That has been investigated here by Sichelbaut et al., and well, they didn't see a major difference between these two solutions, but at least, well, it should be investigated, more investigated in the future, because I didn't find that much data on that topic. In terms of shielding, so limited gantry rotation, some of these gantries do not rotate 360 degrees, which means that the orientation of the beam is primarily in one direction. That has an impact on shielding. Radiation sources are closer to walls, which means that the aspect of distance is of less use in radiation protection. And the embedded facilities the embedded proton facilities are in existing hospital buildings, of course, leads to some more difficulties in getting the dose levels as low as possible, because adjacent to this proton facility, and that's our project here, you see here there are some existing spaces where we have to get, or at least get the exposure to public levels just next to the existing proton facility, and you see that, okay, it's a limited space. We even wanted to squeeze in two systems next to each other. You see that the space we had was fixed. So you see it's a much more difficult problem than just building a facility in open space. This is similar. So that's the Maastricht project, where you see the isodose of the 20 microsievert per week is nicely into the concrete, because there are here adjacent buildings and facilities where there could not be anything above public limits. The space, compact units are smaller. It means that the walls are closer to some of the secondary radiation sources in the beamline, which means that the intensity, the fluence at the level of these walls is higher, and the activation could be higher as well. So the idea of using low europium level concrete are much more important here in these smaller facilities than in the large facilities where distance could be used as well. We go even further into miniaturization to even place a cyclotron in the gantry, to build it into the gantry, and that's a solution commercialized by Mevion. Where you see you have the cyclotron here in the gantry, you have actually the nozzle attached almost to the cyclotron, so there's no bending of the beam, there's nothing. So it's the degrader in the energy selection system, usually it's a bending which is followed by momentum slits to select the right energy. That is obviously not possible in this setup, but everything gets very compact. On the other hand, they have a beamline where there's very little loss, where they're not bending the beam, which means they can run everything at very low proton currents, which is obviously also an advantage looking at secondary and stray radiation. So, embedded facilities, they're small facilities truly integrated in existing environments. Commercial compact system units, basically, well, 1 or 2 treatment room tops, proton beam only, pencil beam scanning only, and they share part of the preparative workflow with existing radiation oncology facilities. And also the staff is shared, and that's really an important point, certainly in the process of going to a justified use of proton therapy. I think it's important to have these mixed environments where people are experienced both in photons and protons, and I think that, well, will introduce maybe less bias than in separate facilities. And usually it's only clinical treatment rooms. And the price is a lot less than these large facilities, well, roughly around 50 million euros. So it can be seen as an additional modality rather than an additional facility, and that's an important aspect. And then in-room imaging, we already got a nice introduction in image-guided radiotherapy. The importance in protons is we know that they do stop in the patient, but there is some uncertainty on where exactly they stop. And you see you can have these dramatic effects. So during treatment, we obviously had an effect on the tumor, that's what we intend to, but you see it has dramatic effects here, exposing parts of the mediastinum to pretty large doses. So we have to keep that in our mind and monitor everything that is happening during treatment, because the effect of this can be almost an overdosage of to 100% of the treatment dose. In photons, that's much less severe. So here you have an example of filling of nasal cavities during treatment. The patient got a cold, and you readily see that has a major impact on the position of this brag peak. And we are introducing image-guided technology. So some centers opted for this in-room CT solution. And co-beam CT is also being introduced. Well, this is a picture that is already more than 20 or 20 years old of the first prototype of co-beam CT on an X-ray linear accelerator. And well, since then it's almost a standard equipment. If you look at co-beam CT being applied in proton therapy, then you see that's actually pretty recent, 2016, one of the first co-beam CTs being used in proton therapy. We want to monitor the delivery process, and one of the interesting things that we can do that actually with secondary radiation as well. One example here is prompt gamma imaging, where we can monitor the delivery process based on the prompt gamma rays that are emitted during the delivery process. The activation of the patient is also being used, and this beta decay can be imaged of these isotopes with a PET camera, and that also gives us an image of the delivery process, and we can verify whether it was located in the right spot. Some concluding remarks. So there is an evolution. We are moving to embedded facilities, and I think that's a very important step in proton therapy to reduce the cost, well, compact facilities, but also improve its integration in mainstream radiotherapy. As you see, these compact systems, they can be scaled more easily by just adding a unit. And you see that, okay, the interface is almost similar to what we are used to in X-ray radiotherapy. That's an X-ray system. This is a proton therapy system of the same vendor. You hardly see any difference in the interface. So in conclusion, PBS has definitely become the preferred technology. So some advantages in dose delivery, less stray radiation, no patient-specific B modifiers needed, and a large number of facilities is moving towards this new mode. Then you see compact systems have been successfully introduced. You see here these are the numbers of systems that IBA has sold. You see that, okay, it indeed gets introduced into the field of proton therapy, and it helps in spreading the technology because of the lower threshold in terms of investment cost. It's a first step in reduction of cost. Definitely we need to evolve further the coming years. It has to reduce even more. They are sold as units, so everything together, accelerator, gantry, and PBS. Miniaturization has some impact on radiation protection, but more studies have to be conducted. It enables embedding of this in existing facilities. That's also important. And it may lead to a more standardized proton therapy, a standardized environment, which is probably an advantage also for data on radiation protection. At the in-room image guidance.
Okay, I think we're out of time.
Okay, just one slide.
Okay, thank you.
So these technologies are being introduced in image-guided proton therapy combined with these treatment monitoring, range verification, in vivo range verification technologies. So we have to find now how we have to combine these technologies in the most optimal way. Looking at proton therapy technology today, well, sticking to this train metaphor, it's really like jumping on a moving train. So it's in full evolution, and we have to get on it as X-ray experienced people. Thank you for your attention.